Hi, it's Dr. William, and welcome to my live. I'm sorry I'm late tonight. I got out of work a little bit late. But anyway, it's not going to affect anything. We're still going to get through everything. Tonight we're going to be talking about tummy tuck. So you're in for a treat because I'm going to be performing live surgery tonight on this person. Not a real patient, but it's going to be exactly what I do, basically. Explain everything so you really understand what a tummy tuck is, and we're going to see how can you go through and get these type of results where your skin looks good when you've had stretch marks and give you a new belly button, tighten the muscles, all of these types of things. So let's start off by just saying, sort of what does a tummy tuck do? What's the purpose of it? What are the goals of it? Well, a tummy tuck really does three things. It will remove the excess skin, it will tighten the abdominal muscles, and it will give you a new belly button. It's your old belly button, but it's a new belly button. I'm going to explain to you how that works, and we're going to talk about that. So, now, what does a tummy tuck not do? Tummy tuck does not give you a small waist, and it does not give you a flat stomach. Well, I know that you're at home watching, and you're probably thinking, oh my God, that's the whole point I'm here. I'm here to have extra skin removed so I can get a flat tummy and a tight abdomen. But it won't do that for you if you have internal fat. So let's start there. So, of course, a tummy tuck is designed to give you a nice flat abdomen and give you a nice small waist. But an obstacle that we cannot overcome is internal fat. So I just briefly want to mention this. Now, there's going to be a couple of slides that you're going to see coming up, and they're going to be graphic. They're going to be from the operating room. So if you're a little bit queasy or if you've got young ones, you don't want to see these slides, and just turn away for a little moment here. But this is what I'm talking about. Here's a patient that had a tummy tuck. But you can see, she had a huge change with the amount of skin that was removed. But you can still see she doesn't look like she's completely flat. And if you look at a different patient from the side, you can see that, yes, all the skin was removed, but she still has that kind of arced shape to the abdomen. And that is because of internal fat. So if you have internal, here are the slides, if you have internal fat, that becomes an obstacle to getting a small waist and a flat abdomen. So that has to be dealt with first. And if I've ever told you to lose weight before having a tummy tuck, that's the reason. I'm not trying to be punitive and penalize you for being overweight. Believe me, I know about that. But I'm just trying to tell you so that you can get a really good result. Because when you look at the results on Instagram or before and afters on a doctor's website, and if you can't obtain those results, then a lot of times it's really because of the internal fat. So it's important to understand that. Here's an example of somebody I did a tummy tuck on. This quite a long time ago. And I probably should not have done a tummy tuck, and I probably should have asked her to lose weight first. But this will explain to you why. So what we're looking at here is the external fat. There's the skin and then the external fat. That fat from that line that goes across the abdomen down, all of that fat, all of that skin and fat, I'm going to remove. That's going to be thrown in the trash. So she's going to have a remarkable change, obviously. But, and here's his slide is a little bit more graphic, she's not going to be flat. And here's why. If you look here at this photo, and just to kind of get you oriented, her head is at the top, and she's sitting in this beach chair, upright position, flex position. We've got the operating room table like this. I'll go into why we do that later. So she's in this position. You can see the drains are in. Now, what you may not be able to see, but if you follow my mouse here, if you follow my mouse, it's kind of right in near the center of the screen. There's a little tiny strand poking up there, and then if you follow my mouse down here, there's also a little knot here. Those are the stitches that I've used to tighten her abdomen. But is her abdomen flat? It's not. Why is it not flat? The skin is not part of it anymore. The skin's out of the picture. So it's nothing to do with her external fat. That was those two big pieces already cut off. So the external fat's out of the picture. But now what you're looking at is the muscles, the abdominal muscle. There's several of them there that go to make our abdomen, that keep our guts in. Well, I've already tightened her abdominal muscles. I've repaired the diastasis, which we're going to talk about. I've repaired that. She's not flat. Why? She's not flat because of what's called visceral fat or internal fat. That's fat on the inside of the body that we cannot get. You are the only person that can remove that fat through weight loss. It's not going to the gym. Gym's fantastic to do. You should go to the gym, but gym is not something for weight loss. Gym is great for strengthening your body, cardiovascular, everything else. But diet is the main way to get rid of internal fat. And you have to eat less calories than you're taking in. You have to burn more calories than you're taking in to be able to burn that internal fat. The good news is your body likes to burn internal fat first. So if you need to lose some weight before a tummy tuck, that's what you're burning. You're burning that internal fat because it's going to ruin your result, and we don't want that. So how do you get a small waist? So let's just say you don't have internal fat, you have excess skin, therefore you're a good candidate for a tummy tuck. Well, a tummy tuck will bring the waist in through the abdominal plication. That is bringing the muscles together. I'm about to show you that. But the real way you get a nice waist is with liposuction. So remember, if you go back to that slide that I mentioned, tummy tuck will remove the skin, tighten the abdomen, give you a new belly button. But if you really want a shape change, then that's where lipo comes in. So most of my tummy tucks, except for someone who's just pure skin, they're very, very thin patients. They may have lost 100 pounds from weight loss, and they just have excess skin, they just have a tummy tuck. But for most patients that also have some fat, that's when we do lipo 360 or tummy tuck 10 we call it, where we go all the way around the body. That's how you really get the shape change. So this type of result here is not just from a tummy tuck. This is from a tummy tuck with lipo. It's a tummy tuck, but we've used liposuction to get the result. So let me take you through the steps of the tummy tuck so we can kind of get all on the same page and figure out what is a tummy tuck. We're going to be talking about complications. That's always my favorite topic because I want you to know the bad with the good. I don't want you to look at this photo and go, heck yeah, that's what I want, sign me up. I want you to also know there's going to be drains we're going to deal with. There's going to be blood thinners for blood clots, all these types of things, the real things to know about having a tummy tuck. Now, just as a precursor, if you are strong enough and brave enough to go through and stay with me for this live, I will give you a QR code where you can get this guide, and this is hot off the press. This is actually really hot off the press. And I wrote this guide, so it has all the information in it that, in my opinion, you would need to know before having a tummy tuck. And it's yours for free. I'm gonna have a QR code, a link up, and you'll be able to get this guide. So stay with me. That's your present. Okay, now let's take a look and let's just go through the steps of what a tummy tuck is. And so I'm just going to use these diagrams here that one of my designers, Manuel, is fantastic, made. And I'm just going to kind of show you the steps of a tummy tuck because I think maybe a lot of people don't sort of know that. So here's somebody here just playing. We haven't done anything. Here's her belly button. And then here she is now. And this is really how the surgery begins. There's a little scalpel representation. And I brought a scalpel because I'm actually going to be using it. We're going to be doing surgery on this person. And I actually have her real before here. So we're going to go through that too. So let's just go through these diagrams to show you. So we take our knife and I make an incision around the belly button. So that's that incision here. And then I make this horizontal incision. Now, everybody always wants that incision as low as you can make it. Of course, we want the exact same thing. I don't want to have a scar up around the middle of your abdomen. But that scar location is actually determined by where your body bends. And everybody bends in a different way. Some patients I have that their tummy tuck scars are incredibly low because they naturally bend in a very, very low position. I have some patients whose tummy tuck scars are a little bit higher than I would like because that's their natural anatomy where they bend. So the first step is we make the incision around the belly button, and the reason we do that, you're going to see in a moment, is because we have to lift up the skin and pull it down. So if we didn't have, if we didn't make an incision around the belly button, we wouldn't be able to do that because the belly button is anchored to your body. It's fixed. So I have to make an incision around the belly button, make the incision here. Once we do that, then I lift up the skin on the abdomen. And I lift up the skin all the way up to what we call the xiphoid, which is the point, the lowest part of your sternum. So all of that skin gets lifted up. And it's important to understand that when that skin gets lifted up, the blood vessels that normally come up here, and they run here, and they're like little sprinkler heads. They run down your abdomen here, and then they pop up. So if you look here, they run down your abdomen, and they're coming up here from your heart, and they come out and they run down your abdomen. And then if you look at it from a section point of view, they send up these little sprinkler heads. They're delivering blood to your skin and your fat. So in order to lift up the abdomen, then what we have to do is we have to cut these blood vessels, because otherwise we wouldn't be able to lift it up and get the skin to move. So once we cut those blood vessels, it's like, well, where in the earth is the blood supply coming from? Well, the blood supply then comes from a different location. The blood supply is coming from the side, from the lateral. There's blood vessels in your back that come around to the front, and they supply that skin. And it's safe to do it. Obviously, we've been doing it for decades because it's other blood supply. Your body has redundant blood supply. Even your hand's a perfect example. It's got a main artery, radial artery that comes in. It's an ulnar artery that comes in. It's a dual blood supply. You can lose one and you can still get blood supply to your hand. So the body has these redundancies. So we cut these out as we lift the skin, but there's blood supply coming in. Once we lift the skin all the way up, we expose all of these muscles. These muscles here are the rectus muscles. And these rectus muscles are what we call paired. So there's one side on each side of the body. And when you're either with weight gain or pregnancy, these muscles will then separate, because at birth the muscles are connected. So if this was somebody at birth, the muscles would be here and they would be connected in the midline, this linea alba, and those muscles are here. But then when you're pregnant or you weight gain, those muscles spread, and a lot of times they'll go back. But they don't usually go all the way back. And some patients, women's tummies after pregnancy, they don't go back very much at all. So there's a little difference from patient to patient. But I can say from experience, if you've had massive weight loss or you've been pregnant, you're going to have diastasis. And there's a lot of discussion about deciding beforehand how much and this and that. It's been my experience that everyone has some degree. Now, if somebody really doesn't have any diastasis, it happens, it's pretty rare, then we don't need to tighten the muscles. But most people, by far, will need some tightening of these muscles. And so what are we doing? We're bringing these muscles here that have separated, we're now bringing them together. So we're trying to recreate what it was like when you were younger and before you were pregnant. And so that's what these are. These are the stitches here. And these muscles, this is just a diagram to show, but these muscles are actually really brought right together. And those are done by stitches. We usually use a couple of rows, sometimes 3. It's a permanent suture, so it stays there with you. We use permanent sutures all over the body all the time, and these are permanent stitches to keep the muscles in where their new location. And then this is just a representation. We put in some drains. So that's what these drains are. I've got some drains here. We're gonna talk about the drains specifically. It's always a hot topic, and we're gonna talk about the drains. But the drains, this will show you, they're sitting on the abdominal wall, And what are they doing? So the drain's purpose is to collect fluid that your body normally handles. But just as when I said we lift up the skin and we cut those blood vessels, also the lymphatic channels, the lymphatic system, which normally handles the fluid, it also gets damaged. The way I think of it is I think of as some bridges that were bombed during a war, and all those bridges are knocked out. That's your regular lymphatic system. That's what happens when I lift the skin up. Those bridges are gone. Then it takes some time. They have to repair all the bridges for the traffic to resume going over the bridges. It takes some time. What happens during that time when the bridges are bombed out and they're not built yet, the system can't handle the fluid, and the fluid can accumulate there. And that's called a seroma. And that's just some lymphatic fluid that's accumulated in this space. That's the space between the skin and the muscle. And so what we do, very simply, is we put a drain in this space. And so this is the typical drain that I use. This is a round drain. I'll mention why later. I use round drains. But it's got little holes on it, it's little channels, and it goes in here, and then the fluid comes out. And the fluid comes out because am I better over here? So the fluid comes out because this drain is held by suction. And so what you do is you just squeeze the we call it a grenade, but it's the bulb reservoir, and you put the cap on top of it, and then the drain is hooked on here. So the drain is hooked on here, and now if there's no air leak, then that will maintain its suction. And that's how you get the fluid that's coming out, because you've created a vacuum, and the fluid will come out the drain, go through these little holes, come out the drain, come into this little bulb. So that's how a drain works, and that's why we put the drains there. There are some surgeons, although I don't think it's as many as used to. It became popular probably 15 years ago for drainless tummy tucks. I used drains for my tummy tucks. I did, through a very short period, not use them, and I had seromas. And I've talked to surgeons that don't use them, and it works for them, but it doesn't work for me, so I'd use drains. And the other reason I always use a drain is because most of the time I'm doing liposuction with my tummy tucks, and that generates a lot of fluid, and you need some place for that fluid to come out. So, tighten the muscles, drains go in, and now this is what we do. So this is a really good sort of way to explain this part. So here's the patient. This is the operating room table, and the patient's laying on the operating room table, and that's where we do all the work. When we lift up the skin and whatnot, tighten the muscle and everything. So if you look at this distance here, though, of how much is open from here to here. So if we look at once I cut the skin off, there's a long distance between the top here and the bottom here, where we're going to have to close those two things together so we can put you back together. You can't be walking around with an open abdomen. So what we do to do that is we put the operating room table. This is Frankie. This is when Frankie's doing some work here. We got to get Frankie to to elevate the bed, and we put the patient in this sort of beach chair position. And what that does is that shortens this distance between these 2 points so that we can then close the abdomen. So we put the patient here, and at that time is when we're determining, once we bend the patient, we can pull the skin down, and that's when we determine, well, how much skin can be removed. And so essentially what I do is I line it up with that where I made the original incision. I line the skin up with that, and then I just make an incision and we remove that. So in this cartoon diagram here, all of this skin here would be removed. And then this is what gets sewn back together. So here, This tissue here, this is all thrown away in the garbage. And then we're going to close the incision over top of the drains. And the drains are there, and the drains are coming out through little separate incisions on their own. And then the belly button. So the belly button, let me just sort of draw it here on the side. The belly button, imagine the belly button, it comes out like this, and it's stuck to your abdomen. It's part of you. I mean, it was connected inside to your baby. So it's there. You can't move the belly button up or down. You can't move it left or right. Sometimes patients will have a belly button that's off center. So it's not right in the midline of their body. It's a little bit to the right, a little bit to the left. I'll usually tell the patient, hey, did you know your belly button's a little bit over here or a little bit over there? And most of the time patients don't know. The reason they don't know, because it's normal, but I can't move that belly button. So I'll say, I can move it a little bit, but if you're too aggressive in how you move it, you get a deformity of it, which I don't like. So I just tell the patient, listen, it's going to be a little bit off center, just like it is right now. And that's where it is because I can't move it. So here's where the belly button is in this diagram. And then the skin, you know, goes over top of this, and that's where you got this excess skin that's hanging down. That's the excess skin that we've removed here in this diagram. So we've removed that, but we can't remove the belly button. The belly button stays there. So when we pull the skin down, we have to bring the belly button out through a new opening. And so that's why make a little incision here. I usually make a diamond incision that's kind of equal width and length, so that it turns out once it heals it becomes more round. And so we bring the belly button out. It's right, bring it up through the skin, make the hole, sew it in to that, and then you're finished. And so that's why you end up with one scar here around your belly button, and then one scar here in the lower position. And normally that scar is well concealed, and you'll see some photos here tonight. That scar is well concealed, usually with any type of bikini or underwear, within reason. So let me just, now that you kind of have an idea, let me just take you through that surgery with this model here. And this is actually, this is not her post-op, but this is a real patient that had surgery with me, and she's actually been on posted and whatnot. She has a fantastic result. A lot of it because she did an amazing, I'm over here, right? She did an amazing amount of working out. But anyway, so you can see she's got redundant skin. She's got fat here in the front. She has, this is all real. She's got fat here in the back and with these rolls. So she had a tummy tuck, and then we did the lipo 360. And so let me just take you through and show you what that, I'll show you here on this model, and I'm going to show you inside what this looks like. I'm gonna lay this down here though. Can you see this okay? Yeah. Okay. So remember what I said. So there's some extra skin here just for demonstration purposes. But imagine she's sort of like this, okay? I make this incision down low in this bikini line. And then, as I mentioned, we lift this skin, and it has some fat underneath it. And we lift that off of the abdominal wall. That's where we're cutting these little blood vessels. These are the muscles here. These red are the muscles. This is the fat. And this is the belly button in black. So then we go through, lift everything up. We're lifting it up because we want to free this skin up so we can move it. And then we tighten the abdominal muscles. And then we bring the skin down. That's where I mentioned to you that we're bending them in that position. We bring the skin down, and then we're going to cut that off. Let me see if I can demonstrate that here. before I do that, just so I can have tension, I'm going to bring the belly button out. So then what we would do, well, I can do the skin. I'll do it like I do in the OR. So here's the skin. Let's see if this will work. So here's the skin. We cut off this excess skin. All right. So that skin is gone. That skin, where am I looking? Okay. So the skin is gone. That gets thrown in medical waste. And now we have skin and we'd be able to tighten that. So after we do that, that's when I'm going to bring out the belly button. So you can see the belly button is coming out through new incision. So here's, let me just feel where her belly button is. I can't feel it very well. So here's our belly button here. It's hard to sort of operate on this little guy. And so, but just so you understand that we're going to bring the skin down, and then this belly button is going to come out through a new opening, like that. So it's why when we say you get a new belly button, it's half true and half not true. It's your belly button, but it comes out through a new opening in the skin. So the skin from where that belly button comes out was actually much higher because we pulled everything down and brought the belly button out through a new opening. So that old belly button where I made the incision, that gets thrown out with the tissue. There is an exception, and I'm not going to complicate it, but there is an exception where sometimes, and I had to do it today, where I make a small little vertical incision too. You can ask me, we can maybe talk about that later, but I don't want to sort of get bogged down with that. But that's a general premise. Lift up the skin, tighten the muscles, bring the belly button out through a new opening, close everything, and then to really get the shape and to bring the waist in. This is actually a real patient, not the pre-op patient for the tummy tuck, but this actually is a real patient. But in order to get this shape, I'm kind of a fan of the OG. So in order to get this shape, that's the lipo. So I usually tell patients a tummy tuck is for you, and the lipo other people will notice, because it's amazing. A lot of times patients will come in, I have no idea how much skin they have, and then they take off their clothes, open their gown, and it's like, wow, there's quite a bit of skin there. Because patients can usually conceal it in their underwear, or they wear a faja, or they wear a binder, or they just wear clothes that fit, and no one really can appreciate that they have excess skin there, but the patient knows. So I always say tummy tuck is a very personal operation. You're not going to have a tummy tuck and walk down the street and everyone's like, whoa, what did you do? But if you get lipo, that's what changes the shape, and that's where people will be like, whoa, what did you do? So, all right, so that's how you do a tummy tuck. That's how the drain works. And let's go through. I'm just going to show you a few before and afters, and I'm going to make some kind of comments as we go to help kind of explain it again, because there's I'm going to put this knife away so I don't hurt myself. And I'm just going to point out a few things and make a few comments. So in general, most of the stretch marks that patients will have on their abdomen will be removed with the tummy tuck. The stretch marks that get removed are the ones below the belly button, because when we're I'm going to go overhead again, one. So let me show this. So let's say I'm doing a tummy tuck on her. I did a tummy tuck on her. This is quite a few years ago. But okay, can you see the overhead here? Okay. So what we would do is normally is I can, and this is a bit of an angle, so if I get this crooked, let me just make this so you can see. Okay, so what we're going to do is, so let's just say we're going to remove some of this tissue here. Her incision would be low, right down here. Usually an incision is in where, if someone's had a C-section, quite often it's there. Unless their C-section is really, really low and made in their mons, then we have to make it a little bit higher. Most of the time it's in the C-section. So here's the incision. And this would be all of the skin here that's removed. So if you have most of your stretch marks, which most people do, coming from like this, then yeah, all of the stretch marks are removed. If you have stretch marks that extend above your belly button, and some people do, then those stretch marks are not going to be removed, but they'll be relocated. And so remember, we're going to be sewing, we're going to be removing all of this skin here. All of this skin here is going to be removed. And so when we remove all of that skin, and we're going to take this incision and bring it down here, and we're going to close this incision, so then it's going to transport those stretch marks down low. So you'll have stretch marks, but these stretch marks that were up higher are now going to be down in this location here. And so you see here in this photo, in this before and after here, you can see how she has stretch marks, but most of them are below her belly button. So she may have one or two that's concealed with her underwear that she's wearing, but you can see that she actually has now like a really nice stomach that's flat, and there's no sign of stretch marks. Doesn't even look like she had a child. So that's the power of doing a tummy tuck, is you can remove that skin. And there's no treatment or cure or fixation of stretch marks. It's just skin that's like a rubber band that's been snapped and broken, and you can't put that together again. So now, not everyone has a nice belly button, okay? And not every plastic surgeon can give you a nice belly button. And I tell patients, I even tell patients my wife doesn't have a great belly button. I didn't do her tummy tuck. Really good surgeon did her tummy tuck. She doesn't have a great belly button. That's just the way it is. Some people just don't have good belly buttons. Now, does it bother her? No. Do I care about it? Not at all. So, but here you can see, and I want to show you, in the before picture, her belly button, you'll see, is kind of poking out. And in the after picture, it's also poking out. Now, if I tried to go through and really try to make that an innie, I would have a high risk of actually killing her belly button. So in this case, I have to say to the patient, listen, your belly button is poking out. It's still going to be poking out. It's just going to be poking out through a new location. But you're going to have a flatter abdomen. You're going to have better skin. You're going to get rid of a lot of stretch marks. Your waist is going to be better because we're tightening the muscles. So there's a lot of benefits to it, but it's nothing is perfect. So and some people really just, they don't have a good-looking belly button. Other people have just beautiful belly buttons. So here it is. Now you can see she's had a really nice shape change, but all of that didn't come from a tummy tuck. That's a tummy tuck with lipo. And so let me just talk about that for a minute, because we can do the lipo at the same time as your tummy tuck, or we can do the lipo later. So let me just kind of use this model here. Let me use, what did I do with the other one? Don't I have another one? Did she run away? Yeah. Okay. Yeah. Okay. So this is another real patient, but she didn't have a tummy tuck. So, but let's talk about lipo and where we do lipo, where it's safe to do lipo, and how we do lipo. So with a tummy tuck, let's pretend that she's having a tummy tuck. So she has incision around here, she has incision down here, and then we're going to do lipo. Well, where I do lipo is I actually still do lipo 360 in a patient with a tummy tuck. But we have to be careful. Remember I said that we're dividing these blood vessels here. So we're weakening the blood supply to the abdomen, to the abdominal skin. So we can't go through and do regular liposuction like we normally do, or we would create a difficulty with the blood supply there. So we usually do, or at least I do, a little bit of lipo up here. But I can't do as much as I can do on the sides, and I can do in the back. So the lipo 360, if I draw it here, if we were drawing on her, if I was marking her before surgery, the lipo here is going to go all the way up in the back, down, through the waist, through the key area here. She's already had lipo, so it's kind of hard to draw it. But so she's had here. That will be lipoed. All of this will be lipoed. All of the side, yes, underneath the arm, not the armpit, but underneath the arm, around the side of the breast. All of this, everything is lipoed. So we can do that at the same time as we do a tummy tuck, or we can do it later. Let me explain to you the advantages and disadvantages of doing it early and late. So if we do a tummy tuck 10, well, it's the same as a tummy tuck lipo 360. It's just 10 areas of lipo. So if we do that, we're doing the lipo and the tummy tuck at the same time. Okay, that's at the same time. Now, I can do it so I just do the tummy tuck, and then we come back 6 months later and we do the lipo. Well, what's the advantage of that? Why would you do it together, or why would you recommend separating it? Okay. If you have a lot of fat in this upper abdomen, it's better to do your liposuction later, because then 6 months after I've done the tummy tuck and all the blood supply is normalized, I can go in and do normal lipo like I normally do, and I can take all the fat. And that's how you get a really flat abdomen. If you don't have that much fat in the upper abdomen, then I can do a little bit of lipo in that upper abdomen safely at the same time as your tummy tuck, as well as doing it all around your body. And the reason why I always do a little bit of lipo in the upper abdomen is for this reason. Now, stay with me here. So, when we're taking this skin, and remember, we were pulling this skin down to make the abdomen flat and get rid of any excess skin. What's happening is we're taking the upper abdomen and we're moving it down to a lower spot. Well, when we do that, if somebody has a very high amount of fat in the upper abdomen, not internal fat, but external fat, when we pull that down, usually in this area here, there's not a lot of fat. And so what happens when I'm trying to sew this piece to this piece, we have a thick piece that we're sewing to a thinner piece. And it became kind of a problem to get those to line up, and you can kind of get like a little deformity there, like a little bump there. So I like to take a little bit of the fat out from that upper part so that I can get these two pieces closer in thickness, so that when they sew them together, they're going to be flat. That's why I do it. But if you have a lot, then I usually will recommend, let's do the tummy tuck, 6 months later we'll do the lipo. Particularly if you want the fat transferred to your butt, it's always better to do the tummy first and do a BBL later. So I said we'll do a tummy and then we'll do later. And so this tummy tuck, or this lipo here, would be either lipo or BBL. It's the same lipo, it's just that we're transferring fat to the butt instead of just doing the lipo. Okay. Is that clear? You guys following me?
They're following you, sir.
Okay. All right, and we're going to stop and take some questions too in a little bit. Let's say 10 minutes, we'll take some questions. So I'm just going to show you a few before and afters. Just number one, people like to see them. And number two, it really helps to explain things. So here's this is an awesome example of somebody who has fairly low internal fat. So when you might look at her before picture, because this happens to me a lot, is I'll say, hey, you need to lose weight before we do your tummy tuck. You have to lose 20 pounds. We can't do it. And the patient will be like, well, I just saw a post and the patient looked exactly like me, and I don't understand why I've got to lose weight and she didn't, and she looks good. It's because of where the fat is located. And that's the main thing. So if you look here at a before photo, you might say like, wow, she's too heavy to perform a tummy tuck. She needs to lose weight first. But if you examine her, what you realize is most of that fat is on the outside. And so when I'm doing that little maneuver here where I'm pulling this down, I'm going to be cutting off all of that. All of that stuff's going out. So she'll still look good after. Here she is after. She's lifting up her shirt. She's happy with her abdomen. And she's flat. Could she be a little bit flatter? Yes. She would have to lose a little bit of weight to get rid of the internal fat. But most of her fat was external, which is why you can do a tummy tuck in somebody here who looks like they have too much internal fat, but they don't, and then you can get a nice result. So it depends on where the fat is. Okay. Here again, this is someone who gets a better shape change. This is because of the liposuction that was done, so all through her flanks. Now, to be honest, if we look at her after photo, is she as sculpted as this patient? No, she's not. She's a little bit straighter. But if you look at her before photo, you can see she's a little bit naturally straighter. So everybody has a different waist. Some people have, there's some patients that I've seen, I just can't even believe their waist. Their natural waist, when I can feel it when I examine them. And then when we remove the fat with the lipo, we can expose that. And then everyone's like, wow, that's fantastic, you did a great job. I just did the same thing that I do, but she just happens to have a beautiful waist. And she has a very small waist. This patient here, great change, she's happy, but not as sculpted because she naturally has a waist that's not as small. Okay. And so here's a point I want to talk about when we're talking about the waist. So this is a Manuel did this. This is a diagram, again, showing those abdominal muscles that are open. This is the diastasis. I'm going to write that down. This is diastasis. No one ever used to know what diastasis is. Now everyone talks about it all the time to me. So diastasis is that separation of your abdominal muscles. That's what it is. And that's how it looks. And then we go in and we put these stitches in and we reapproximate the muscles together so that they start to come in closer. Now, I wish that everyone, I'm just going to go through that again. I wish that everyone would get this amount of waist reduction with the plication of the muscles. But this is not a fair representation of what happens with a tummy tuck. It's the concept, it's the idea, it's the goal. We want to bring those muscles in. Some people will get a really dramatic result from just bringing the muscles in. I can see it when the patient's on the table. But for most people, it's a little bit more subtle. And to really get the waist part of it, it's not just the muscles coming in, but it's also the lipo. So you can see here, she has a pretty small waist, and it's not all from the plication. It's also from the lipo. Once again, you would say, oh, gee, I look like that, and you've told me to lose weight. No, it's because her fat was all external fat, so I can remove it. I can cut that off. And the interesting thing to me, too, is that a high amount of external fat in a tummy tuck patient, in that really kind of doughy skin with all the stretch marks, that fat is very resistant and difficult to lose. And it even is harder to come out with liposuction. I don't know why, to be honest with you. I'm not sure, but there's a different consistency to that fat that has been stretched and returned, and maybe it's a hormonal contribution from pregnancy. Truthfully, I just don't know. But that fat that's there is perfect for removing because it's all on the outside. Okay, so, and these, I would say that's a remarkable result, and I'm not just sort of patting myself on the back, but it's a combination of the tummy and the lipo. So, okay, I'll just show you a few results. You can see where her bikini, this is not a real bikini, this was just added afterwards so we could show it and not get banned. You can actually see that her bikini, if you look here on the right image, and on the right side, which is actually her left part of the body, you can actually see the bikini is coming up higher than the scar is. You can see her scar down below. And then that scar is down low throughout. And so most people end up with a scar that's very manageable. Nobody wants a scar. Nobody wants a scar. Any single person that comes to me, tummy tuck, they always say, I don't really want the scar. Nobody does. I don't blame you. But it's a pretty good trade. in most cases, where you can get rid of that skin and restore the abdominal wall and get a new belly button, and it's usually good for the scar. Let me just mention something about the scar, and that is, if we look at the quality of the scar and where that scar is, and also how that compares to a C-section scar. I'm going to write C-section here so I don't forget to talk about that. So now, your scar will go usually, down low in this area here. So that's where the typical scar is. The scar is different in different parts of this line. And so this is not usually talked about very much, but I'm going to talk about it. So this part of your scar here in the center is usually the worst part of the scar. It's a scar that usually spreads more than anywhere. Remember, if we're talking about a scar, what are we looking for? Well, I have a very fancy, complicated way of analyzing scars. It's a 3-point system. So one, the scar has to be flat. These are the factors. These are the features for a good scar. Okay, if you have 3 out of 3, you're gonna have a good scar. It has to be flat. It has to be thin, and it has to have a pigment match. Okay, so the color has to stay the same. Now I don't know. Does this show up on here? One down. Okay, can you see this scar here?
Yeah.
It projects okay? Yeah. All right, so you see how it's white? That's why I had a carpal tunnel release there. So, Dr. Globman, love the man. So that scar here is white. That's hypopigmented. So a scar can either be hypopigmented, so the pigment cells that are there just turn off and you get a white, lighter scar, a pink scar, or it can match the color. So you can't really see the scar. So I move over here.
Yeah.
So it can match the color, and that's perfect. That's what we want. Or it can be hyper. And so can you see this? All this dark pigment here. That's where I got hit on when I was riding my bike, and he knocked me off. And it was a Raptor, Ford Raptor. And it was a big truck, and you can see now as it's healed, it's got dark pigmentation there. So that's hyper pigmented. So if your scar is flat, thin, and matches, that's a perfect scar. Usually in the center of the abdomen, you will get a flat scar, and you'll usually get a scar that's a little bit darker or a little bit lighter. So the pigment is usually not perfect there. And the scar has a harder time being thin in this central area. And why is that? Why am I telling you this? Because I want you to know. So when we're pulling down and we're bringing this together, so when we're pulling this skin down to be able to make that incision and close that incision, there's more tension. Woman down. There's more tension on that part of the scar than there is if we go to this outer part here. So usually the scar that heals the best, that's usually flat, that's usually thin, and the pigment's pretty good, are the scars to the outside, which happens to be a very good thing, because as the incision's low and it's coming up, these are the parts that are harder to conceal with a bikini. So I can remember from firsthand experience, my wife had twins, she had a tummy tuck, and I remember the first time going to the pool with her. This is in North Carolina, got little kids running around, and she was worried that people were going to see her scar. And so I noticed she was moving her bikini up constantly. Every time she got out of the chair to run after one of these little blankety blanks, then she would adjust. Well, you get up and down, you're running after the kids long enough, you're like, whatever, I'm not adjusting it. I'm like, honey, you can't even tell, don't worry about it. You could see it at the time. It was red because it was still early in her healing. But it was harder to conceal. But given time, a year, that scar fades. So you really don't need to be putting your bikini up to adjust it because you really don't see it. But the scar that you see more frequently is this lower one in the middle where there's more tension on the scar because of the way we close, and that's why that scar doesn't look as good. But the good news is it's the lowest part of the scar. So scars tend to have an arc here where patients bend. So it's the lowest part. So it's the easiest scar to conceal. So even though it's the worst, it's not as bad. Okay, so that's one thing I want to mention about the scar. C-section. So patients will usually say, will my scar be, my C-section scar healed super well, so I'm expecting my tummy tuck scar to heal and look exactly the same. And that's why I say, whoa, Nelly. No, it probably won't look as good as your C-section scar. And I know what you're thinking. Well, how can that be? You're a plastic surgeon. You're going to close this scar. And that was an OBGYN who are maybe not necessarily known for their scar closing ability. Yes, I did say that. Come at me. Okay, so, but the reason their scars look good here is because we are doing the opposite procedure than they are with a C-section. So with a C-section, you're starting out, obviously, pregnant, everything is stretched and distended, then out comes the baby, the placenta, and all the amniotic fluid, and everything shrinks. And so now, when you're closing that incision from the C-section, there's no tension. It's the opposite. The skin is trying to contract. There's no, it's loosey-goosey. Whereas when we're doing a tummy tuck, we're removing skin and we're pulling things down. And we want people to be taut and flat and have a good, nice abdomen, so we get rid of that skin. We don't want to have any extra skin there. And that increased tension is the enemy to getting a good scar. So that's why typically C-section scars are better than tummy tuck scars. Is that the case all the time? No. I've seen lots of people who've had bad C-section scars and they want me to remove it, which I do with the tummy tuck, we normally do, and then they get a better scar and they're happy. So, but by and large, that's a really important point to understand. Okay, I don't remember why I put this slide in, but that's another after for her tummy. Similar thing here, another after. You can see that her belly button is a little off there. That is probably me, not her. Stretch marks, just so you get an idea. Okay, let's take a break here, and let me take some questions. And how am I going to do the questions? Am I going to, oh, you got that. Okay, let's go through the questions. Actually, before we do the questions, let me show you something. I want to mention this, because this is something pretty cool. So it's this. You recognize that little icon? So this is Reddit. So I have a Reddit, and it's going to be an r/Dr. William Miami. It's the same handle as all my social media, YouTube and Instagram and TikTok and all that. But what this is this is a little different community. It's really a community. It's different than an Instagram, which is in a lot of ways kind of a one-way dialogue where, I do answer questions there, but it's principally sort of me explaining things. Whereas this Reddit community is you can go and join, and the nice thing about it is it's anonymous. So you can be comfortable asking questions. And what I really see happening with Reddit is being able to have kind of a community, people that have had surgery with me, people that haven't had surgery with me, people that have questions about surgery, and then I can have a dialogue there. The other nice thing about Reddit is they don't have the restrictions for the nudity that they have in the other social media platforms, because it's a little tighter controlled communities. And so you have to be age verified to enter. So I can show some things there, and if they're too graphic, they'll just put a little black screen on it, so you're not going to be like, when you're scrolling. But I would encourage you to join. as I think you're going to get a lot of value of it. I'm going to be able to explain some things in a little bit better way, I think, perhaps, doing that without some of the other encumbrances. And I think we're going to be able to have a little bit more dialogue together. And I also think, and I hope anyway, that people will have dialogue with each other. And we can really kind of have it as a little group, or a little community, a little village of like-minded people who are trying to sort of, gain information. The most important thing, all right, enough Reddit. So the most important thing, though, is to be educated and to understand. And it doesn't have to be just me just blabbing. I mean, I talk a lot. It doesn't have to be me just telling you things. It's also helpful to get patients' experience. And so if we have this little community in the Reddit environment, in this subreddit, then I think that it'll be helpful. Anyway, so feel free to join there. Now, let's get to some questions here. Where should I go? The bottom? Are those the most recent?
Yeah.
Okay. All right, Lexi. If you've had a tummy tuck in the past but have bulging up to and below, can you can you remove that? All right, or redo a tummy tuck. Let me just address this. So, most commonly, after patients have a tummy tuck, they will have, if they're not happy and they're not flat as they want to be, they will have a bulge. Can you also do this when I'm answering the questions?
Yep.
Okay, so they may still have a bulge in their upper abdomen, and that's usually internal fat. So that we cannot fix with lipo or tummy tuck. It's also not very common to do a repeat tummy tuck. People will have a repeat BBL, that's pretty common, but repeat tummy tuck, or like a round 2 tummy tuck, is really not something that exists, because that skin doesn't grow back unless somebody's gained a lot of weight, or they've perhaps had twins after their tummy tuck, or they've had bariatric surgery and they've lost weight, and then they've lost a lot of weight and they really just don't have any fat, and they can have some extra skin, and then we could do another tummy tuck. I don't do that often. It's just coincidentally, I did it last week, but I don't do it very often because it's not a scenario that comes up very much. But, so if it's internal fat, cannot help you. If it's extra skin from a lot of weight loss, then yes, we can do a tummy tuck, but it's not a very common scenario. If it is external fat that's there, then we can help you. And that's actually pretty common. So the reason this is common is because what I was talking about before, if somebody has quite a bit of fat, external fat, and we do the tummy tuck, remember, we can't lipo all of that fat in the front like we can on the sides and the back. So if somebody has tummy tuck and they're not as flat as they want to be, then this is actually my very favorite thing to do, is to go and perform liposuction. Because what they've done is they've converted themselves from a tummy tuck patient with, this extra skin here, and they've converted themselves by removing that skin to just a pure lipo patient. So then we can really go and we can get all of the fat, and we can really give them a good contour. So I don't know if where you fall into that, Lexi, but you're going to be in one of those categories. Okay, Priscilla Tamayo says, can you do a tummy tuck, lipo, and breast lift all in one? The short answer to that is yes. And that is if you're medically healthy and don't have any, significant medical problems, obviously. But yes, that can all be done at the same time. Elizabeth asked me, do I work on patients who've had major weight loss? Yes, every single day, really. I don't know why, but it's really common. Lost 130 pounds. Yeah, I don't have specific slides here. I do have slides of patients that have had massive weight loss, and I think the thing that people who have massive weight loss is they don't realize that they're skinny, and so sometimes patients will come in and they'll have lost whatever 130, 140 pounds, 110 pounds, 80 pounds, something, a lot, and they'll come in and they'll be for a tummy tuck, and then they'll say, well, I want lipo as well. And then usually, because I'm sitting down low, kind of looking, and then I usually give them the old, what? And I mean, the things that come out of my mouth during a consultation, it would absolutely floor you. I have no idea how I'm still in business, to be honest with you. But, but the reason they're asking me is because they think they're fat, but they don't have any fat. They just have skin. So I'm like, no, you don't need anything. You just need a tummy tuck. There is no fat to take. You've taken all of the internal and you've taken all the external. So there's nothing left. So some patients that have lost that much weight, they don't feel as if they're skinny because they have all that skin. And it's wonderful to be part of that whole process where they go through, they lose all the weight, and they have this skin, and I come in like I'm the savior. They've done all the work, and I just trim a little skin off, and then they've got this flat abdomen. So yes, I do that a lot. I like to do it because it's a really good feeling. Particularly in patients, sometimes patients are very, very young, even before they've had children, and they could be 22, 23, but they were obese as an adolescent, and then they got above 18 or whatever the reason, and then they had a bypass or whatever the weight loss mechanism is, they lost it on their own, and then it's really nice to be able to help those patients. Very gratifying. Let's see. Okay, Monica Brown's talking about how long do you have to wear the faja after surgery. Let's just talk about the faja for a minute. So with the faja, I start all my patients off in an abdominal binder. But I don't like the term because it sounds like we're really, binding them, and it's something that's really compressing. The problem I see so often today is with over compression. And so I don't like patients to do that, to be over compressed, particularly when you've had a tummy tuck, because that can actually be dangerous. If you're putting too much pressure on that, what we call the flap. This is the flap. So we call this the flap. Everything for us plastic surgery is flaps. We do flaps all over the place. So this is what's called a flap. And so remember, the blood supply is not what it used to be. So when we pull this down, now we're relying on the blood supply coming in from the outsides. And the blood supply here is not as good as it was before surgery. Because before surgery, you had blood supply from everywhere. We've cut that blood supply in order to raise the skin, create the flap. But if you put too much pressure on the flap, too much compression, then you're going to kill that flap. And I've seen healing problems from that more than I care to. And it's because patients are pushing, trying to compress. You are not going to compress your way to a flat tummy. If your tummy is not flat after a tummy tuck, it's because you have internal fat and you need to lose weight. Straight up. So I don't like a bunch of compression here. But what I do like is providing patients with support of their back and comfort. And that's what a binder will do. But I'm not using it to compress them. So that binder just goes around here. I have patients wear that for 2 weeks. There is a protocol, by the way. Remember, I got a protocol for everything. There's a protocol here in the OG recovery, this guide for tummy tuck. This is a protocol which will show my whole recovery protocol. We don't have time to get into it tonight. But that protocol, I start patients wearing a faja 2 weeks after surgery. 2 weeks after surgery, even if they've had lipo. And if they've had the 360 lipo, they wear the foams on the sides and they wear the board in the back. The board in the back is for preventing a seroma. And so they'll do that, and then a couple of weeks, I have them get in a faja, and I have them use FiberGuard. Now, if you've ever heard me talk about FiberGuard, you know it's my little baby. I love her. And because it's amazing, but I use it in tummy tucks too, and I never thought I would. I only thought I would use it in lipo patients. But I saw the skin in patients who had lipo, who I actually thought they needed a tummy tuck, and they used FiberGuard, and their skin was great. Now, I'm not saying that you don't need a tummy tuck and you wear FiberGuard. I don't want to leave you with that impression because that's totally not true. But it is very, 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 very helpful for getting good skin. So at 2 weeks after a tummy tuck with lipo, I have my patients, or just with a tummy tuck, I have my patients stop the foams, stop the binder, stop the tablet in the back, and move to FiberGuard directly on their skin, and they wear a faja, and they continue that for 12 weeks. Okay. Let's see, Sonia, there is no maximum age for this procedure. It depends on your health. If you're healthy, doesn't really matter. If you're 62 and you're healthy and you're 42 and you're diabetes and hypertension and obesity and high cholesterol, then you're a better candidate at 62. So it's not age, it's to do. Miss Lockett, thank you very much. I love that comment. Appreciate it. Okay, Rachel. See, this is why you got to take questions. I should just stop talking, just take questions. Does this hurt like a C-section, Rachel? Thank you for asking that question. The answer to that is no, it does not hurt like a C-section. It's actually worse. So the reason it's worse is because what I was talking about before, when you have a baby, you're stretched out. So when they close you, there's no tension there. And when we do a tummy tuck, it's the opposite. Plus, when we do the lipo itself hurts like hell. That's a reality. So tummy tuck and lipo, that's not a picnic, and it hurts more than a C-section. And the final reason why it hurts more than a C-section, although only one time a patient asked me, she said to me, my C-section hurt more. She came back and told me after, my C-section hurt more. And I'm like, okay, well, you're the exception that proves the rule. But my experience, most everyone says, no, this is worse. And the other reason why it hurts more is because of what's going on in your brain, chemistry. When you have a baby, you get massive release of endorphins and a whole bunch of other things that I don't even understand that make you mask pain. And the perfect example that I can remember from this is when my oldest son had some immature lungs, he ended up in step down. We were very nervous, first-time parents. Oh my God, our son's not coming straight to the room. And so I remember my wife getting up very shortly after surgery against everyone's wishes, and she just basically said, I don't care, I'm going to see him. And that was everything in her brain. She didn't care about anything. She didn't care about any pain. She just C-section didn't even phase her, didn't even bother her, because she had all of those things in the mother, what's it called? The mother instinct. And wanted to do it. After tummy tuck, there is no instinct. You've paid for the tummy tuck. You know, we're not giving you something. So it's not the same as a C-section. And in my opinion, and my experience, my patient, it hurts worse, except for that one patient. Okay, thank you very much for the compliments. I love that because I'm a plastic surgeon, so I have a egotistical personality and I need constant reinforcement. So thank you. Okay, Bridget Hilton, my main goal is to have a BBL. So should tummy tuck come after this procedure, or what order is preferred? Well, I'm quite opinionated about this. 100% best answer, have your tummy tuck first. No question. Because let's just take this patient here. This is like I said, this is a real patient. Can you see this? Should I be over here? Here? Okay. So she's got some excess skin here. If I go in and lipo this, and I have a slide coming up, which is gonna lead into, you're gonna love this slide, because it's gonna show what happens if you have lipo when you really should have had a tummy tuck. I'm gonna show you those pictures. But so what a tummy tuck will do is we'll change this patient from not being a very good liposuction candidate. I remove the skin, and now we change her from someone with excess skin tummy tuck patient to somebody who's a lipo patient. And now I can remove all of that fat. We don't have to worry about any excess skin, and you get a good result. The problem is, if we do the lipo first, it creates scar tissue. Liposuction creates scar tissue. That's why I don't like J-plasma and all those other things. Scar tissue in this flap. I love this little thing you guys made. These guys behind over here are talented beyond anything else. And anyway, so, I mean, we're now taking real patients and making before and afters out of models like this, and it looks so amazing. But anyhow, okay, so what was I talking? All right, so if we do the liposuction first, what happens? We get scar tissue. Where is the scar tissue form? It goes underneath this flap. So when I get scar tissue underneath this flap, it makes it harder to pull and stretch. And so if you do the liposuction before the tummy tuck, you get scar tissue here, and it's harder to do your tummy tuck, and it doesn't look as good, in my opinion. So I like to do the tummy tuck first when everything's nice and soft. We get a nice pull, get everything tight. Now, we come back later, get rid of the fat, sculpt the body, bada bing, bada bang, there you go. All right, how long is the recovery process, Sonia says, and it really depends. You could probably have to take about 2 weeks downtime. I usually tell patients if you have a surgery on, say, a Thursday, you'll probably be back to work, not the Monday, but the following Monday. And then it's 6 weeks until you're doing everything you normally do, lifting, all that stuff, working out, heavy, anything. 6 weeks is totally fine to do that. And I usually have patients kind of start at 3 weeks and do some gentle, if they want to get back to the gym, they can do some treadmill or something, but nothing like heavy lifting. Heavy lifting is fine after 6 weeks. Can you do a tummy tuck twice? Technically you can, but it's not very common. K, is a virtual evaluation available? Short answer is no, I don't do virtuals. And I'll tell you why I don't do virtuals, because I just found them to be very, very difficult to schedule it and also to see the patient, because I like to see a patient naked, no underwear, see everything that we're dealing with, see where the incision would be. I could see all of the butt, the side, everything. And when I try to do that with a virtual, number one, it's a little awkward for somebody to kind of be like that and that in their house, and I sort of feel awkward looking at them that way. But and when I've done them, I've had a nurse with me. I don't even know if that helps, but whatever. Makes me feel more comfortable. But I just can't see very well. I get the phone or the computer, and it's moved, and there's angles, and it's really hard. And all the way that we look at patients, I looked at them in a very standardized way over and over and over again. So what we do for our out-of-town patients, which we do have out-of-town patients, then what they will do is they'll usually send still photographs, front, back, side, other side, and good light, no selfies, and very, straight kind of, you're getting your mugshot taken like that. So then I can really see. So, and then I'll look at the photos, and the coordinator associate can talk to you. Okay. Let's see. I don't know what that means. VH says, do we order our FAHA week PO to start wearing a week maybe before surgery or after surgery? Yeah, usually it's better to wait for your FAHA, because then we can just measure you and we can really see what the change is. If you order it beforehand, you're guessing a little bit. Usually we'll tell patients, take your measurements and then go down one size for that. Celeste, no, I do not practice in New York. I'm only licensed in Florida. Let me give you a shout out to the guide, because I will say every one of these questions that you have is answered in this guide. If it's not, please comment somewhere, YouTube, Instagram, and say, hey, you never talked about this, and I'll put it in the guide. I mean, I can change it and write it and reprint it, and it's available digitally, so it's very easy to change. But I really did put a lot of time into it, and have covered a lot of answers in there. So if you wait to the end here, we'll give you a QR code, and you can download that guide for free. Can you have lipo and no tummy tuck with a fupa? Yes. So the reason you get a tummy tuck is if you have extra skin. The reason you may have a fupa is either from internal fat or external fat, or both of them. If it's primarily external fat, then liposuction alone will take care of that. If you don't have extra skin, we can't do a tummy tuck. If there is no extra skin, we just simply can't bring that down. Brenda, how long do I need to stay in Miami after a tummy tuck? You're going to stay in Miami for at least a week after surgery. That's what I recommend for everyone. We're going to handle the drains. We can handle the massages. I can see you. There can be, make sure that everything is good. And it's not safe to travel after a tummy tuck so soon. So we want you up, walking, moving around before we do that. Wellness says, can you have a mummy makeover and BBL together? Well, it's impossible to answer that question because a mummy makeover is no one surgery. Mummy makeover just means we're operating on your breast, we're operating on your tummy. So, can you have a BBL with a breast augmentation? Yes, you can. Can you have a BBL with a breast lift? No. Can you have BBL with a breast reduction? No. Can you have BBL with breast reduction? With a breast lift and implants? No. So, a BBL is safe to have with a breast augmentation. That's a safe procedure to do because it's okay to lie on your breast after having surgery if you've had a breast augmentation, because we're just putting the implant in and we're not changing all the blood supply. If we're doing a reduction or lift with implants, we're changing the blood supply to the nipple, and then it's not safe to lay on your breast, and you have to lay on your breast when you have a BBL because you got to lay on your tummy, you can't lay on your back. Okay. The Yariadol, I can't read that, I'm sorry. I have the OG roller, I love it so much. The OG roller is fantastic. It's probably not going to be around much longer, unfortunately, because it is manufactured in China and it's going to be it's already a very expensive product. I don't take that product and mark it up like crazy. It's an expensive product for me to get. You can't even believe the design that goes into it and the intellectual property. There's a lot of things in that little roller to make it heat and vibrate, and detachable handles and everything. So I'm probably not going to be able to reorder another batch of them because of the tariffs. But it is fantastic. I love it. And I really hate that I'm in that situation. Let's see. Okay, Priscilla, you're saying, how can I get direct consultation with me? It's simple. I see people every day. Just call the office, make an appointment, and come in and see me. It's no more complicated than that. There's no charge to a consultation. Just come in and I'll see you. And if you have to lose weight, I will tell you. If you have a medical problem that would not be safe, I will tell you. Sometimes it's kind of unfortunate as someone come in and the first thing they tell me is whatever their medical problem is, and I say, nice to meet you, this is just a social visit, because I can't operate on somebody with certain medical conditions like sickle cell, or people with hypercoagulable states where they're at risk for developing a blood clot. Okay, I'm going to take question. Let me do one more question, and then I'm going to go back and we'll give a few more answer. I'm going to talk for a little bit longer. Then we'll do another round of questions, and then we will wrap it up. Yes, Celeste, if it does, but it just, who knows if they are. One day it's on, one day it's off, so it's really hard to tell. Okay, Maciel Ferreira, do I plasma? I typically don't recommend J-plasma because of the concerns when I add heat to that area. Do I do it? I still do it. Sometimes patients want me to do it, so I'll do it. But my personal preference is not to do it because I think the heat and the thermal energy from it, it's helium-based, creates more scar tissue. And I am, at this stage in my career, I feel that I'm comfortable doing the operations, and so then I kind of shifted and said, well, okay, how can we get patients better results? And that's through recovery. And so I've really focused a lot of energy on recovery and on the skin quality, activating the lymphatic system. If you want to hear me go on a tangent, just ask me about the lymphatic system, okay? Because I'm very in tune with that. That's how the roller works. That's how FibroGuard works, by getting really, really good skin. So I don't recommend J-plasma because I think it gives you more scarring. Okay, are we, can I go back to the talk? Okay, so let's go back to the talk. I'm going to talk to you, speaking of recovery, I'm going to talk to you, thank you, I'm going to talk to you about some drain care briefly. This was a carousel, so I've just taken the slides from there, and we're going to talk about some drains. So, drains here, I told you, why they're placed. They're usually placed out on the sides. They come out through separate incisions. I'm actually going to skip through this because I'm going to talk about it more here. But what I'm trying to explain to you in this video is and what I failed to mention earlier when I was talking about the drain, But if you weren't here when we were talking about the drain, here's another chance to see it. And something I didn't mention before is drain stripping. So, okay. So just, let's say if you didn't see this part of the YouTube before, which I don't blame you, it's got other things to do in your life. If this is a drain inside of you, not all of this part is inside of you. The part actually where these two, 1 dot and 2 dots, this part is inside of you. I'm here. This side is in you, and then I can trim this too. I usually don't have to though. So it's really only about this part that's active that's inside. It's a soft, elastic tube. It doesn't hurt when it's inside. It can be uncomfortable where it exits the skin. That's where it can bother patients. Where it comes out of the skin, and it can move around a little bit there. Even though I sew it in with a couple sutures, it can still move a little bit and irritate people. But the drain itself doesn't hurt. Anyway, this goes in. It has little openings here that go into the drain itself. The part that's outside of your skin doesn't have these holes. Excuse me, doesn't have the holes. And then the drain gets connected to this drain. We call it a grenade for obvious reasons, or a bulb or a reservoir, one of those things. So what this has on it is it has a little port here, and this drain functions by squeezing it, and you hear the air come out of it, and then when you put this port back on, you cover it. I'm just going to kink this drain so that no air comes in, because when it's inside of you, there isn't any air inside your body coming out here. So when you kink this, then it maintains the suction. So this now is collapsed. This is how a functioning drain is supposed to look like. It's collapsed, and then the fluid will come out of your body and go down through here. You can have little floaters or little goobers that come in here, blood clots. They can look disgusting and concerning and terrible, but they're totally normal, not harmful. I'm going to go through the color of the drains here in a minute. And then in order to empty the drain, you're then going to open this little thing, and that will remove the suction, and then you're simply going to just squeeze, and the fluid comes out. And then you write that down, you record it, and you record it for a period of 24 hours, then the next day for 24 hours, so we know what the drain outputs are. As the drain outputs come down, then we can take the drains out. Now, something very important, maybe a little hard for me to show you here, but what we do is, so this won't hold suction here, but what we do then, let's pretend that's collapsed, is I'll hold tension, and I teach patients to do this, or really Karina teaches patients to do this, is this is held, let's say your skin is here, so this is right where it's exiting your body. And then what we do, and actually Karina showed me this little trick, I didn't know this for years, is you take this and you pinch it. Now you have to secure it against the skin so you're not pulling it out and hurting the patient. So you put one hand here, and this hand is kind of pulling towards the patient, or yourself if you're doing it yourself. It's holding there, and that'll provide the tension. And then you're going to take this and you're going to strip it. So you're going to pull it along here, and by doing that, you're moving the fluid along the drain, and you're moving any of those little goobers or floaters or blood clots. Then you're going to pinch it again, and then you're going to strip it. And so what Karina does, she actually takes a little bit of our foam soap, the little dispensers, and she puts it on here. And it's really nice, because then it's clean, but then it's more lubricated, and it makes it easier to do the stripping. So I always know if patients are stripping their drains or they're not, because the drains come with a little surveillance chip. Now, the drains will be, if somebody's really stripping the drains, they get longer. So sometimes patients will come in and we have to trim the drain, put the bulb on, because they've stretched the drain out from the stripping. I love those people. If you're one of them, I love you. You're doing a great job because you're stripping. If you're not stripping your drains, they can get clogged, because you can have clogs in here. And remember, the whole reason for a drain is to get rid of the seroma, to prevent the seroma, and to get rid of the lymphatic fluid that's building up. but there's also blood there because we just operated, so you can have little blood clots that can get in here and they can clog this drain. So you want to keep stripping it to keep moving it along. Okay, let's talk about I'm going to skip through this part here because I think it's not as helpful as I thought it would be. Okay, that's a point there. If you look at this slide, can you see that slide there? So you can get some irritation there. And actually that area can become red. And it looks like an infection, and most people think it's an infection. It's not. It's inflammation and it's irritation. And it's just because the drain has a little bit of movement there. And if your drain's only in for a week, then you're not going to develop that. But there are patients that will have their drains for longer, depending on their drain output. And if they have their drain longer, they can develop some redness there, or even they will develop what looks like an infection. So they say, oh, my drain is infected. Well, I'm not going to go into the explanation why, but drains actually can't become infected because it's an open, but anyway. But patients will say, my drain is infected, there's pus at my drain site. It's not. What it is the epidermis, the top layer of the skin, has been worn away from that drain moving around a little bit, and it will show you the underlying dermis, which is white, and that can be interpreted as pus, but it's not. It's just traction. Okay, this is how the drains typically sort of progress in time. So the drain will start out red, and because there's more blood in it, because we've just finished operating. Now, we're not leaving you with blood vessels in there that are leaking, that are, pumping out blood, but there's still blood. We just finished surgery. So that blood will color the lymphatic fluid, turning it this kind of cherry pink or whatever color, that salmon color. So your drain will usually start off a little bit redder, and then over time it starts to get lighter, and usually as it gets lighter, the output starts to decrease. So that's kind of the normal progression of drains. It doesn't, I could talk for, there's a lot in the guide about drains. I know, because I wrote it and I kept writing and writing and writing and writing and writing. There's a lot of information in the guide about the drains. But the drains will go through a bunch of different colors, and usually this is how it goes. Drains typically will put out different amounts from both sides. They're never the same. Sometimes Monday, the right drain is putting out more, and sometimes Tuesday the left drain's putting out more. Doesn't matter. Doesn't matter if they're the same. Doesn't matter if one drain is putting out very, very little or nothing and the other one's putting out more. None of that matters. They're going to be different. Two sides of your body is different. And just to make things worse, the drain on this side is actually over here draining that side, and the drain on this side draining that side. So anyway, that's how it goes. There's a few signs about the fluid that are concerning. So if your drain is not a nice clear color and it's murky or it's milky or it's cloudy, that can indicate an infection. So that would be a time to go see your surgeon. If the drain is really dark maroon color, that is old blood. So what that means is there was a hematoma, meaning you bled after surgery inside that area. Not so much that you noticed it or your surgeon noticed it, because if somebody has a hematoma, we can usually see it. Thankfully, it doesn't happen very often. But if there's a hematoma, we can see it, and it's a bulge or a lot of bruising. Patients will have tension there. It'll be painful. So that's a real hematoma that you can see, and then we'd go into the operating room, open that up, and drain it. For patients that don't have that, they can still have a small hematoma inside. And the way your body works is the moment your blood clot forms, your body actually starts releasing factors to dissolve the blood clot. But the blood clot takes a time to get organized, to form into that clot itself rather than just being loose blood. It forms into the clot, and then it usually takes about a week or so for that then to liquefy. And when that clot liquefies, your body's breaking it down itself. That liquefaction liquid of the hematoma then is a very dark color, and that'll come out in your drain and it appears as dark. And if that happens, it happens to my patients too. If that happens, that dark fluid, we usually will leave the drain in until that dark fluid is gone or mostly gone, and then it's safe to remove the drain. We don't want to leave a hematoma there because blood is like, I don't know, spare ribs or hamburger, fried, something delicious. So, not good for you. But that's what the bacteria think of blood. They're like, oh, this is great. Here we go, full buffet. And then you can lead to an infection. So we want to, if you're starting to liquefy that hematoma and it's coming out, we want to continue that process until it's over so there's not the heme and the blood in there that the bacteria like to get at and cause an infection. Okay. I'm gonna go through these because just for interest of time. I talked to you about the Reddit. I'm really excited about that. I see it as an opportunity to do something a little bit different and have kind of this community feel. Maybe I'll be the only one there, who knows? But if you want to join me, come on in. You're welcome. And it's anonymous, which is great. Just, don't be swearing at me, and I don't know who you are, but ask questions, and it's nice and more comfortable. So, all right, remember I said I'm going to show you this slide? If somebody had liposuction because they didn't want to have a tummy tuck scar, and it's okay. Most of the times I can do it. If somebody really has a lot of excess skin, it's just I can't do the lipo because it's moving too much. I tell patients the same thing. It's kind of like playing soccer with a Publix shopping bag, this plastic bag. Like you just can't do it. Whereas you need a nice hard ball to kick. So with liposuction, I can do it if you have excess skin. I try to get you to do a tummy tuck, but not everyone wants to do a tummy tuck. So, but then your skin, you have to understand that liposuction, tummy tuck, two totally different things. And so you're not getting the same result. Here's a patient that was a candidate for tummy, in my opinion, would have been a better candidate for a tummy tuck. And she didn't want it. So she has a great shape change. You can see she was fairly square or rectangular or, quadrant. Anyway, you know what I'm talking about. And she was here, and then now she's got some shape. But because of the excess skin, she has excess skin. So there are patients that are totally fine with this. And it typically is a bit of an older patient. And they'll say, listen, I'm not wearing a bikini anymore. I'm not even wearing a bathing suit. I just don't like my shape. And I say, well, you're going to have quite a bit of extra skin. And people ask me, they'll say, how will my skin look? And I will say, terrible. That's what I say. And because I don't like to mince words, I want people to know. And so sometimes that will stop people in their tracks and be like, whoa. Okay, I thought I'd have a little bit of skin. I'll be like, no, you're going to have a lot of skin. Skin's not going to look good. If you're only interested in the shape and you don't mind the skin, no problem. And there certainly are patients that are like that. And I respect that. I'm not trying to tell patients what to do. I'm making suggestions. I've seen a lot of this. And so I kind of know where things may be going. And if I think, she doesn't really know where they're going, let me tell her in no uncertain terms, your skin will look terrible. It may convince her to say, okay, let me think about that. Maybe I'll do a tummy tuck. I'll say, okay, that's great. We'll get you good skin, get you good shape, get both. But if they say, no, I know that, I'm not really worried about that, we can do lipo. But you just have to know what you're getting into. Here's another example. Somebody that tummy tuck and they didn't. So, anyhow, this is what we prefer to do. Get rid of all that so we're nice and flat. And then if that patient wanted to go and have lipo later, like she probably be, listen, this starts getting really nitpicky. But if I look at that photo here, she's happy. I'm happy. Everyone's happy. But if I look at this, does she have a little bit of fullness in this area that I could lipo out? Yes. And that's what I was talking about earlier when you can get that discrepancy between that upper part and the lower part. So when you bring them down, you can get more fullness there than you like. That's why it's great to come back and somebody's a tummy tuck because I can remove all of that, whereas I couldn't do it at the time because it's not safe. Okay, I think what we're going to do Yeah, look here. Yeah, some really amazing things that you can do. Tummy tuck results look dramatic because of that hanging skin and it just disappears. Oh, I wanted to talk to you about this patient because she's got some healing problems, and you can see them here. And if you look, does that show up?
Yeah.
Okay, so you can see them here. Can you see my mouse just above this black triangle? That is a what we call wound dehiscence. Now there's different layers of dehiscence, but that is dehiscence. Okay, I want to talk about this too. Let me talk about the dehiscence first. So, what is dehiscence? Dehiscence is just something coming open. So when I was, when I did, remember I did my general surgery training first, and then I did my plastic surgery residency. And so when I did my plastic surgery at Duke, and when I was there, I got permission from the department that I could do what's called moonlighting. So I had 3 young kids at the time, and we had enrolled them in travel hockey, which is very expensive. And so I needed to get a part-time job. So as I was a general surgeon, I could moonlight as a general surgeon. And I would go to some of these small communities in North Carolina. And I remember in particular, I went to this one office, and I was seeing a patient in a room, and the nurse came into the room. She's like, and I really didn't know her, I was just filling in. She's like, I need you right now. And if you work with a medical assistant or a nurse for a long time, you understand if they say that, then they probably mean it. But I didn't know her, so I just thought, well, let me finish with this patient, I'll be right with you. And she's like, no, I need you to come right now. So I'm like, oh, okay. Well, I don't know her, but I understand what that means. So I went into the room next door, and I walked in the room, and this man had a lot of his guts coming out. Okay, that is what we call a dehiscence. But that is a dehiscence of the fascia. So this person had a surgery a few weeks before, a couple weeks, I don't remember, and the wound, the fascia that was holding all the guts in, that was sewn together, came apart. So you can imagine it was pretty dramatic, and like, okay, we're gonna have to take you to the operating room, sir. And I took him across the street to the hospital, and I closed him again, and he did fine. But that's a significant dehiscence. So if you hear that term, you're like, wow. But there's all different levels of dehiscence. So what we're talking about, and what we're talking about in this patient here, is some separation of the incision. And if you see it, you'll see it typically in that front center part, for those reasons I mentioned when we're talking about when I was talking about the scarring, and I was talking how there's more tension here when you close in this central portion. So this is where you're going to get more potential for wound separation, which is dehiscence. So the wound separation is usually very mild, and what it is if here's your incision, and you can have, well, that's wrong. So here's your incision, and then you can have a little area here that separates. And it can be like this. It can be disconcerting for patients. Usually patients think it's an infection. It's not. It's just a separation. And it's got to do with the blood supply, and you lost a little bit of blood supply to some of that skin there, and that skin died, and now you're seeing a little opening. That heals on its own. It heals fine. You might have a little bit wider scar in that area. You may not, but that's what it is. That's a separation. It's not going to, your guts are not going to come out, because when we close the abdomen, I close the abdomen in 3 layers, and one of the layers, the deepest one, is a very big stitch. It's very strong, and so there's 3 layers. So when we talk about a separation, it's usually just involving that first layer, which is our weakest layer. It's just brought to bring the skin together, and you can get that. But it's something to know. Here I put this in here for you. I thought this was kind of fun. I've seen this a gazillion times. And if you look here in her before photo on the left side, and you look around her belly button, you see that little scar above her belly button. That's from an abdominal piercing. And then if you look on her after photo, you'll see where that scar is. And so it's always amazing to see, like, holy cow, that scar moved from there to there. And it tells you how much skin came out. And then her new belly button is brought out through that new skin. So if you follow my mouse here on the before photo, this or go back to the right side, her belly button is coming through skin that was up here somewhere. And you can actually see, it's very faint, but you can see over here there's a mole, and over here the mole comes down. Over here there's a mole, and now you see the moles come down. So we're talking about fairly dramatic excisions of skin. Excuse me. I have, as usual, a lot more to talk about. So we'll probably have to have a part 2 to this. But I'm going to call it here in the interest of time so everyone can get to bed. Let me answer some more questions, and then from there we will wrap it up. So let's do 10 minutes of questions, and then I'll be coming home. Remember, I'm going to give you this QR code here in a minute so you can get this free guide, which is really, I think it's really good. I put quite a bit of work into it because I want patients to really understand what they're getting into, how to recover, all that stuff. It goes through medical things and common questions and all that. All right, questions? Okay, questions are loading. Any questions from our audience here tonight?
Yeah.
You have a question there?
A couple of you were doing the training. Okay, Regina asked, have you ever had a person have drains in for more than the time period that is required? And if so, do they have their own doctors pull them out?
Okay, so for as far as and let me know when you get that one. For because I think it's kind of awkward this way. So anyway, for length of time with drains. So the drains, it's like this. So the drain output will typically be sort of like this over time. Oh, wonderful. So there is no required time, there's no set time, there's nothing, because this time course is variable from patient to patient. So if that's day 0, that's your surgery day, and this is 7 days after surgery, that output may be great. I mean, when we could take the drain out at 7 days. That could be 14 days. That could be 16 days. I've had patients with drains for over 3 weeks. Not common, but it's possible. So there's no set amount of time for the drain to be in. It's not time dependent, it's dependent on the output of the fluid. Excuse me. Because if we take a drain out too soon, what happens? The fluid accumulates there. So you can't take the drain out earlier, like, oh, it's a week, I'm leaving, I gotta have my drain taken out. You might have to go home with the drain. So usually in that case, the patient's family doctor will remove the drain in the office. Sometimes I've talked to them, but most doctors know how to do it. It's not very complicated. And I've had patients who are nurses or patients with nurses' friends, and I've instructed them how to do it, and they can do it. It's not particularly complicated to remove a drain, so it's usually not really too much of an issue. Okay, Celeste, how often is drain stripping required? If you can't over strip a drain. So if you see there's fluid there's a little clot or something, just strip it. So you can do that a dozen times a day. Can I still wear my FiberGuard after 5 weeks from a BBL? Yes. I don't know if you're asking, should you wear it longer than 5 weeks, or can you start it at 5 weeks? The answer to both is yes. FiberGuard is most effective if it's used 2 weeks after starting 2 weeks after surgery. For tummy tuck, that's when I do it. BBLs, I start it at 2 weeks as well. And but usually I'll have patients wear it for much longer than that, than the 5 weeks. I usually have them wear it for 3 months. But they're only wearing it 12 hours a day. Can I wear FiberGuard 1 week after tummy tuck? I don't advise that. I usually have my patients start 2. I worry that the FiberGuard will irritate their scar and you'll get that dehiscence or that scar separation, with that. Jessica, I answered that question with that sort of patient with the skin. You don't have to have a tummy tuck. I'm not authoritarian telling patients you have to have a tummy tuck. I just recommend things and make suggestions, and if it falls within what's safe or what's ethical or what's I think is good, then yes, I'll do that. If you don't want to have a tummy tuck, it's okay. You just have to understand tummy tuck and lipo are 2 different things. They give you different results. So I always say lipo is like ice cream, makes everything better. So I think it's good to add lipo to a tummy tuck. If you don't want a tummy tuck, you don't have to have it. You just have to recognize that there may be skin issues there that you may or may not be okay with afterwards. Melissa says, can you do arm lipo with a tummy tuck 10? Technically, Louisa, thank you for saying that. It's very nice of you. Technically, I can do arm lipo with a tummy tuck 10. Do I do it? No. I don't do it because it's a very big recovery from a tummy tuck and 360 lipo. This is a big surgery. We're not going into your abdomen. We're not going into your pelvis. We're not going into your chest. We're not operating your heart. But it's still a very big surgery. And so what I worry about with a tummy tuck is people, I want them up and walking frequently to prevent a blood clot. And how are you getting up after a tummy tuck is you're going to be doing this. And what are you going to be if I lipo your arms? This is going to handicap you. And I don't want that. I want you up and walking. I don't want you to be like, oh, my arms hurt. I don't really want to get up. No, I don't want that. I want your arms not to be operated on. So I don't combine arm lipo with a tummy tuck. And people do, but I just don't do it. Priscilla, that is really up to you. If you want, when can you start being intimate after a tummy tuck? I would really encourage you. Could you put a link up to that podcast with Larice and her husband? Is that possible? Yeah. Because she talks about it in pretty good detail as to when they started having intimate relations. But the general rule is, in my opinion, is when you can do it in a safe manner. So at 3 weeks, your tummy tuck scar is usually pretty strong. It's not strong enough to do heavy lifting, but if things were carefully done and orchestrated, then yes, I think it would be fine at 3 weeks. At 6 weeks, there's no restrictions on any activity that you do. You could lift and do everything. So let me know if, so did you put that up there?
Yeah.
Oh, God, you guys are fast. Oh, I'd love to be young again. All right, so there's a link there. So watch it. It's a podcast. It's Larice. She's awesome. Larice, she gets her photos are old or videos or whatever that's on YouTube, but sometimes people comment on them, and they're always like, oh, she needs to go to the gym. And I'm like, you have no idea how this lady's going to the gym. She completely transformed her body, and I loved it. I helped her out with it, with the tummy and things. And she's really, really, if you meet her, she's impressive. And so is her husband. And so I had them on a podcast to talk about their recovery from a tummy tuck, and she talked about it and was really good. And her husband was there, and her husband's a great guy. And they started talking about when they had sex and everything else. So it's fun. All right. Shadow touch, can I discuss a fleur-de-lis recovery? Fleur-de-lis recovery is really the same as a tummy tuck. Having a fleur-de-lis, for those people that don't know, fleur-de-lis is from the what you see on like the New Orleans Saints helmet. If you're a football fan, it's that French sort of fleur-de-lis. It's fleur-de-lis. I was corrected by somebody who speaks French, and I always used to correct people for saying fleur-de-lis. It's fleur-de-lis. Anyway, it's this diet, it's this shape, and the reason why we talk about tummy tucks usually for patients that have lost massive weight. And so if we look at their abdomen, a fleur-de-lis scar comes all the way down here, the middle, and then a regular tummy tuck scar here. And I know patients gasped when they saw that me draw that right now, because people are like, I don't want to have a scar down there. Well, if you've lost a lot of weight and you have a lot of extra skin, then you may want to have that vertical scar because we can get you totally flat. Usually these types of patients have zero internal fat. They're very, very skinny patients, and it's dramatic when we do this operation. Now, why do we call it the fleur-de-lis if this incision looks like an upside down T? It's because what we're taking is the tissue like this, and then we're taking this tissue here. And so that's where you kind of get this fleur-de-lis concept. And I guess it probably like that if you... So then we're taking skin. This is worth mentioning. We're taking skin here in both the vertical direction. So typically when patients gain weight or lose weight or are pregnant, and they'll develop extra skin in the vertical component. So the extra skin will be down. And all these pictures, look at the picture that's on the screen here, the person has extra skin in his vertical dimension. But for patients that have lost a lot of weight and have a lot of skin, not only will they have this vertical excess, but they also have horizontal excess. So if I just do a tummy tuck on that patient, then what happens is when they bend over, they will have extra skin here in the middle part of their abdomen. And I've had patients say, I don't like this. And I'm like, okay, well, no problem, but you're going to need a scar in the midline. And back in the days, and when I was doing tummy tucks back then, people never minded this scar after massive weight loss because they already had a scar from their weight loss surgery. But now with everything done laparoscopically, we don't have patients with this vertical midline scar anymore, so not a lot of people would like it. But if you really do have a lot of excess skin in this horizontal direction, then this is a really good operation. But the recovery is about the same as a regular tummy tuck. That was the answer to the question she asked 10 minutes ago. Okay, and I can tell now because I can see where the question is, where your thing is. All right. Okay, yeah, so here you go. She lost over 210 pounds. So I'm getting a fleur-de-lis and a Mons lift and lipo. Yes, good for you. That you're going to get the best result that way. How long should you wait after hiatal hernia repair? I usually recommend 2 months after hernia repair for any type of surgery, but always get clearance from your surgeon. And a hiatal hernia is a little bit different. That surgery is sort of going on the inside compared to the outside. No, I do not do scans to determine whether fat is internal or external. I can see it. I can feel it. I can see it in a photo most of the time. Not all the time, but quite often. Okay. No, Melissa. Oh my goodness. Does a fiber guard need to be worn with the board and the foam together? No. No, 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 no. You stop the boards and the foams at 2 weeks. The boards and the foams are there for a different reason. I'll talk about that another time. But the boards are there to prevent a seroma. They're not there to get you skinny. They're not there to get rid of any internal fat. They're not there for your skin. In my opinion, they're actually working against you for the skin. We use the boards at the beginning to prevent a seroma. Once you're out of that window of risk of developing a seroma over the first 2 weeks, we get rid of the board, we get rid of the foams, and that's when I use the fiber guard. Okay, Nafisa, I don't know. I don't do any scheduling or any of that type of stuff, but go ahead and contact the office and they can help you with all that. And Sonia wants to know, will the recovery after surgery take place same location or is it an outpatient procedure? All patients come in and go home on the same day of surgery. Yes, hey Sandy, FiberGuard is worn under the faja, right against the skin. I start my patients on it 2 weeks. I can't resist talking about the lymphatic system, so let me just talk about it for a brief moment here. And if you've seen a YouTube live of mine before, you've probably seen this diagram, but this is the best way to explain it. So, let's just say this is the skin here up top. You got a couple layers, epidermis, your dermis, and then underneath that you're going to have fat. And so here's fat. Look at me now. I got this iPad. I can see if things are projecting or not, although it's slow. Okay, oh, it looks good. All right, there's your fat. And then you're going to have an artery that's going to come through. That sends up those little sprinklers to the skin. Then you're going to have a vein. Veins are blue. They usually run with the arteries. And here's the veins. And then, and the whole purpose of FiberGuard and a roller and lymphatic massages and everything, I love manual lymphatic drainage massages. They talk about it, but they're wonderful. Any type of surgery you have, I mean any type of surgery, in my opinion, a knee ACL repair on a young kid, I would get them a manual lymphatic drainage massage. It's a totally underrated specialty. These poor MLD therapists, they're just working with no one knows them. I mean, they're fantastic people, and they do great work. And they're activating the lymphatic system. You know how long they've been saying this? Decades. Do you know how long we've been listening to them? Never. But I listen to them. I read their book. I've talked to them. I've met them. I've worked with them. I love them. They're fantastic. Here's why. It's activating the lymphatic system, and this is how FiberGuard works. And the lymphatic system are these little vessels that are kind of hanging out in here. Nobody pays much attention to them because you can't see them. They're translucent. They're just full of clear lymphatic fluid. It's clear. It's like water. And they're very, very small. Some of these lymphatics are only like a few cells thick when you get down to the end. They're very, very tiny, but they're super important. And when you take this, so this is the skin, the fat, and then, you know, lower down here, you got the muscle. And so you got your red blood cell, you got your red is your arteries, your blue is the veins, the green is the lymphatic vessels. We want the lymphatic vessels to be open. When they're open, they draw fluid in. That fluid gets returned to your heart, goes to your kidneys, and you pee it out. That's how you get rid of the fluid, the swelling after surgery. It's your lymphatic system, and your kidneys are getting rid of the fluid. If you go and you compress it, we need to do that at the beginning to prevent the seroma if we're talking lipo. We compress it because we want to close down the dead space so the fluid has no place to accumulate. But if you compress too much, too long, after the time where you need to for preventing the seroma, you're going to compress the lymphatic system. You're not going to get the fluid. I'm talking little tiny little fluid here. That fluid's not going to leave. Inflammatory mediators kind of pool, have a party, set up shop there, and that's where you get fibrosis, and that's where you get scarring. I've seen this, I don't know, many times. So now, since I've been using the FiberGuard, I got the FiberGuard idea from the manual lymphatic drainage therapists. They taught me the system. I just made it simpler. I said, well, rather than using little foams and placing them here and there, you know, higgly-piggly, put them in the FiberGuard all in once. And since I've done that, it's been like light bulb, boop, why didn't I do this earlier? We're getting really nice skin because we're opening up lymphatic channels, we're getting rid of the fluid, getting rid of the inflammatory mediators, getting soft fascia, soft skin, everything's hunky-dory. So the FiberGuard sits on top here with these little spheres. Looks like it does nothing. I haven't even talked to other surgeons outside of my practice about this because I know if I tell them, hey, you should wear this, they're going to look at it and go, you know, what are you doing? That's nothing. It's low foam. Oh, no, it's nothing. It does a lot. It does a lot. And by these little micro movements here, mimicking what a manual lymphatic drainage therapist does, it opens the channels and the fluid goes in the lymphatic channels and it gets out. So, quite partial to that. And the reason I am is because it works, and I've seen it work time and time and time again. I don't have a study published on it. I don't have anything to hang my hat on, but just my experience, and my experience is it really works. Okay, 2 more questions, and we are going to go to bed. I got to go to work in the morning. All right, Angelique Sanchez, do seromas feel hard? No, they feel the opposite. They feel soft. Seromas are just that collection of lymphatic fluid that's underneath. sorry about that, that's underneath here. And so the fluid is collecting in this little spot here. And so when you have the fluid, it kind of will tent up the skin and bulge it out a little bit. It'll bulge it out a little bit, and then you can feel it. And then if you poke it, if I'm checking for someone as a seroma, quite often you can see a little swelling compared to the other side, or sometimes in the whole lower abdomen. Most of the seromas are in lower abdomen, which is why we have people wear the board in the front. Not with the tummy tuck. Never compress the tummy tuck with a board. It's dangerous. But we can see like a little bulge there, and I just take my finger and it's like, poof, and then give it a little poke like the Pillsbury Doughboy, and then you will see a fluid wave, because it's just water, it's lymphatic fluid. And so you'll see a little wave, and then you can see that wave perpetuating through the skin. And it's easy to treat. We'll just take a needle right at the bedside, put that in, and draw it out. Okay. One more. Oh, Melissa, you asked a really good question. This is fantastic. I'm 3 months post-op and my tummy feels bloated. Is this normal? Yes. Thank you for asking that question. And I don't think it's in my guide, actually. It's not in my guide. So, Paula, if you're watching, remind me to put it in my guide tomorrow. So, this is really common. And you know where I learned this from? I learned this from my wife. Because she had twins, she had a tummy tuck, and, well, first of all, I remember very clearly, it was like a Saturday morning or Sunday morning, because I was laying in bed. She was in getting dressed in the, at the end of the bed. And then I looked at her and I said, are you sure you really do need a tummy tuck? Okay, I'm a plastic surgery resident at the time. I was doing tummy tucks. And her head snapped around the poltergeist way, and she said, well, you may be used to having things hanging over your pants, but I'm not. And I was like, okay, noted. So anyway, so she had her tummy tuck, and then at about that 3 month time, I love just like a setup. At about that time, my wife said to me, I don't understand this. I had a tummy tuck, and I can't fit into the jeans I was wearing before my tummy tuck. And I'm like, I don't know. Because I didn't know at the time. I had no idea. I'm like, I don't know, talk to Dr. Zen. That was her surgeon at Duke. He trained me. Super smart guy, very good surgeon. And so I don't remember if she asked him or what I told her or anything. But then I went into practice. I started doing tummy tucks. And then people started telling me this all the time. All the time. And I'm like, that's what happened to my wife. And this is how we learn about recovery as surgeons. We don't know anything about recovery. We only knew how to do the operation, who's a candidate, don't do this, don't do that, because that'll, we know that, but we don't know about recovery. We just don't know until we start operating and treating patients, and people come in. And so we learn. When you're a young surgeon, you're not telling patients, I don't know, I'm learning from you, but yeah, that's exactly what we're doing. And so it was really common. And I don't have a good answer for your question as to why you're bloated at 3 months after having a tummy tuck. But it is really common, and it goes away. So that's all I can really tell you. If you're still bloated at 6 months, it's not the same thing that's going on. If you're still bloated at 6 months, that's because internal fat, and that would give you that distension. But for people that don't have internal fat and they feel bloated 3 months, it's something that happens. Okay, thank you, Paula. Look at her. Woo woo. Okay, now do I inject fat in? Of course. Who's injecting fat into muscle? All right, that's it. I'm gonna call it there. Thank you guys for watching. Thank you for the questions. We've got to. Can you post this is good, but I do have to add that point in here about the bloating. I'll do that tomorrow. But that's really good, so you can download that guide, and there's a lot of information there. If it's not, then leave me a comment and let me know, because like that question you just saw in real time, maybe you have to add something. So are we good? Is the thing up there, the QR code? Okay, all right, here it is. So scan the QR code. If they're watching it on their phone, then it's available tomorrow as a link in the video. Is that?
We're putting it in the chat so they can.
Okay, it's in the chat, so you can just click on it there.
Yeah.
All right. So that's it. that's Tummy Tuck. I'm going to have to do a part 2 to this. I don't know exactly when I'll do that. It depends on how the Florida Panthers play tomorrow. But thank you so much for watching. Really great questions. I sincerely appreciate your questions. I think sometimes people think, oh, you got to do a live. Yeah, I got to live. No, I like doing lives because it's the interaction and it's the questions. And I feel good if I'm helping people answer these questions. And so thank you so much. Great questions tonight. Look forward to seeing you again. Remember, join my Reddit. Just the same. It's a subreddit. And it's just the same. Dr. William Miami, that's the handle for it. Join it, trying to build a little community so we can have stuff like this. So we can kind of talk a little bit more. I think that would be fun to have that interact. Anyway, good night. Thank you so much. See you next time. Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Light goes through the key area, round, fill in the hip, blend that into the leg. I've got my pen and paper out today. I want to talk about. Okay. Yeah, okay, relax.
Welcome to my YouTube channel.